We're going to start off by having a look at the different types of facial injuries. When we talk about facial injuries, these can include any soft tissue injuries to the anterior portion of the head, so the forehead, the eyes, the nose, the ear, the cheeks, the mouth, and the chin, and also any fractures of those regions as well. Facial injuries can bleed quite significantly because it's a highly vascularized area, and often the bleeding looks a lot worse than what it really is. The other thing we need to be aware of with facial injuries is because we're dealing with the upper airway structures, if there's any bleeding or structural deformity in the nasal cavity or the oral cavity, this patient's airway could be compromised, and we need to then start thinking about the best tools to use to manage the patient's airway in that circumstance. Another aspect to also consider is the fact that in our society, the way that we look, and particularly the way our face looks and is presented, has a very large impact on the psychology of the patient. So when dealing with facial injuries, patients may have a higher range of anxiety and fear associated with the injury because of the possibility of permanent deformity or permanent damage to their face. Common soft tissue injuries to the face and the head include scalp wounds, lacerations to the face or the head, avulsions, abrasions, and penetrations. Different types of facial fractures can include fractures of the nasal bone, the zygomas, which are the cheekbones, the mandible and the maxilla, so the top jaw and the bottom jaw, and the different varying types of Le Fort fractures. Facial fractures can be highly traumatic for a person because, as I've mentioned, this can change their physical appearance, and there is the possibility of an associated head or brain injury due to the forces exerted and the mechanism for the fracture to occur. The Le Fort fractures are the most severe group of facial fractures. There are three different types of Le Fort fractures, and these are brought on generally by severe blunt force trauma to the face, which requires a very strong or forceful mechanism of injury in order for these to occur. And as these types of fractures can only be caused by quite a significant blunt force trauma to the face, they generally are associated with a type of head injury and C-spine injury. The first type of Le Fort fracture is a fracture that runs bilaterally through the maxilla and through the base of the nasal cavity there. The second type of Le Fort fracture runs through the upper portions of the maxilla bilaterally and through the bottom of the orbital rims and over higher up on the nasal cavity or through the nasal bone. And the third type of Le Fort fracture runs through the mid-face bilaterally, so running from temple to temple, directly through the orbits and through the top of the nasal bone. These three types of fractures could have multiple different types of complications and involvements with other tissues. Looking primarily at Le Fort 1 and 2, because of the trauma to the nasal bone and the upper portions of the oral cavity, we could be looking at swelling and edema in the upper airways, hemorrhage in the upper airways, and major structural deformity that could cause obstruction and occlusion of the person's airway, making them difficult to ventilate and compromising their overall oxygenation and ventilation. Then looking more towards the Le Fort 2 and Le Fort 3 type fractures where the orbits are now involved, these patients could have quite severe damage to the eyes. They could have vision loss, and they could have interfered with multiple facial nerves at that point. So we may see the eyes looking in strange types of gazes, either looking upwards or both the pupils are not reacting effectively or equally any longer. During your assessment of these types of fractures, assess the face visually for symmetry within the face. So look at the left side of the face and look at the right side of the face, checking for symmetry. Wherever you see asymmetry, there could be possible fractures there if it's not a normal asymmetry for that person. When palpating over each of the bones, if the patient has a good level of consciousness and is able to tell you something is more painful or more tender as you palpate it, be aware of your position to be able to try and differentiate between the Le Fort 1, 2, and 3. Assess the patient's pupils, looking for equal and reactive pupil constriction to light. Also observe the gaze that the patient may have. The eyes might be looking in different directions, or the patient could have a gaze or a stare to a particular side, or the eyes could be looking in opposite directions to one another. Look inside the nasal cavity, so looking through the nares with your pupil torch, assessing for any swelling or discoloration, deformity, and hemorrhaging. When assessing inside the mouth, look for discoloration, for swelling, deformity, bleeding, and loose teeth or any other foreign objects in the oral cavity, as well as palpating for any deformities on that maxilla and nasal bone. When managing a patient with a Le Fort fracture, we need to be very aware because of the high mechanism of injury. There could also possibly be head injuries and concussions. The patient may have a decreased level of consciousness as a result of this. We need to be very careful about our airway management and ensuring that the airway remains open and clear of any hemorrhage or any obstructions. The different airway devices we can have a look at if indicated, and if the patient unconscious with no intact gag reflex, is something like the oral pharyngeal airway, or the i-gel or LMA would probably be more appropriate because it provides more protection to the patient's airway if there's any hemorrhaging and swelling. The nasopharyngeal airway is contraindicated in any patient with nasal fractures, Le Fort fractures, or base of skull fracture. That is because insertion of this could cause penetration into the brain, so we're never to use these on any of those patients. Assess the patient's ventilations, and where necessary, we're going to support their ventilations and provide intermittent positive pressure ventilations, or IPPV. Just remember that whenever inserting an LMA or an i-gel, we should be using our BVM as well to provide those assisted ventilations or completely taking over the patient's ventilations. Assessing the patient's circulation, it's important to ensure that you control any external hemorrhaging. Establish IV access, whether it just to keep the vein accessible to administer things such as medications, or to actually administer a fluid challenge where blood pressures are below 90 systolic. Depending on the patient's level of consciousness, will also help you identify what medications you're going to administer for pain relief. Using something such as Entonox, where the patient has to hold a face mask to their face on someone with facial fractures, is not the best method of providing pain relief. And again, using something like fentanyl intranasally is also going to be contraindicated because of damage to the nasal cavity. And when assessing this patient's sample history and the mechanism of injury involved, we might need to be considering things such as a C-spine injury, and then being able to manage C-spine stabilization and spinal immobilization. And then while transporting these patients to hospital, ensure that you're constantly going back and reevaluating the airway, breathing and circulation and the patient's vital signs, and making adjustments where necessary. We're now going to move on to the different classifications of skull fractures. Linear fracture is the most common type of skull fracture that occurs, and approximately 80% of all skull fractures are linear fractures. Linear fractures are basically a crack within the skull where there's been no displacement of that tissue. The skull is still intact. There's minimal neurological deficit that occurs from the fracture itself. However, there can still be quite significant brain tissue damage underlying that fracture, which we'll talk about a little bit later on in the presentation. And these types of fractures also generally don't require surgery in order to heal. The next type is the basilar skull fractures, or the base of skull fractures. The base of skull fracture is again one of the most common sites of a skull fracture because the bones in the base of the skull are very thin, which we discussed at the beginning of this presentation. It's any type of fracture that occurs within the base of the skull. So we could have a linear fracture in the base of the skull. And remember that the base of the skull consists of anything from this occipital region here, running through the posterior region of the face, through these finer bones behind the orbits here to the front of the skull. With the mechanism of all skull fractures, there's a high possibility of a chance for spinal injury as well, or a vertebral injury. But in particular, the base of skull fracture has a high association with the C1 and C2 fractures because they're joined at the site where the spine meets that base of the skull. And if there's been significant amount of force transformation to this region over here, there's also a higher possibility of high cervical spine injuries as well. Hallmark signs of the base of skull fractures or basilar skull fractures are signs such as raccoon eyes, and we've got a few good pictures to depict these in the slides to follow, where patients have ecchymosis around the orbits under the eyes, so they look like they've got two black eyes, and battle signs, where there's ecchymosis or bruising behind the ear, showing that there's blood collection in that region there, as well as blood accumulation and cerebrospinal fluid in the ear canal and in the ears. Now, the battle signs and raccoon eyes are late signs. They generally only start to develop within a couple of hours to days after the incident has occurred. So you might not witness these on an actual scene. However, seeing the blood or fluid collection within the ear canal is more likely. Depressed skull fractures occur when the bone fragments have been displaced in towards the skull and they damage the underlying tissues such as the brain and the meninges. Be very careful and wary when palpating the person's skull. You may feel what's often described as a boggy mass, the soft, squishy area which is not consistent with the rest of the skull. Because of the nature of the depressed skull fracture, they can cause severe underlying damage to the brain tissue with a high chance of cerebral edema and hemorrhage. Open skull fractures have a very high mortality rate associated with them. They're prone to infection as well. We have a great diagram on the right-hand side showing a young child with a very clear open skull fracture. Here we have the scalp on the outer lying surfaces. We have the white periosteum attached onto the skull, and these are the fragments of the skull with the gray matter underneath. It's very clear also in this diagram that the meninges have been ruptured. When we have a look at the dressings around the boy's head, we can see bits of blood, but there's also damp fluid outlining those areas of blood, and that's the cerebral spinal fluid. And once the meninges have been ruptured and exposed to the elements, we have a huge portal of entry of infection into that area. Infections of the brain and the meninges are incredibly difficult to treat, and because of the high mechanism of injury involved with these types of fractures, there's often severe brain trauma that occurs, and that's why we get these associated high mortality rates. Some of the specific and general signs and symptoms from a skull fracture can include bleeding from the ears, which is otorrhea, and usually that blood is mixed with cerebral spinal fluid. Having a look at this diagram in front of us, we can see there's the blood on the sheet underneath the patient, and there's this halo of cerebral spinal fluid that has separated from the blood and extends further out on the dressing or the sheet. This is actually called the halo test. It's how you can identify if there is cerebral spinal fluid mixed in with the blood. And this is a clear indication that the meninges have been torn because there's leaking of cerebral spinal fluid out of the ear. We can also have rhinorrhea, which is blood and cerebral spinal fluid coming out of the nose. Also a clear indication that there has been rupturing of the meninges, and those can happen in a number of different types of fractures. Here we've got a great picture of a depressed skull fracture. We can see very clearly the depression in the frontal bone of the skull over here. You may also note that there's changes to the position of the eye. So the eye on the left-hand side is looking straight forward, but the eye on the right-hand side is pointing inwards. So you may have different types of abnormal stares or gazes. Also, when assessing the pupils of the patient, we may notice that there could be pupillary changes to light reaction and size and shape. Then the common signs and symptoms of a base of skull fracture or basilar skull fracture is the raccoon eyes, so the ecchymosis or hemorrhage under the skin around the eyes and the orbits, battle signs behind the ears, and then blood or fluid build up inside the ear canal, and that's actually having a look at the patient's eardrum. We can see that there's a buildup of blood behind it. The patient may also even indicate to you, if they're conscious, that they feel like they have fluid filling up within their ear canal, or it feels like they've got water in their ear. And this could also be associated with acute hearing loss or acute hearing disturbances. Other signs and symptoms could be a decrease in the level of consciousness following blunt or penetrating trauma to the head, pain and tenderness to the site, obvious deformity or an obvious open wound, and most importantly is looking at the mechanism of injury and the history of the event.